I'm Dr. Michaeli. I'm a peripheral nerve and reconstructive surgeon. I'm briefly going to touch upon spinal cord injuries. Why am I talking about spinal cord injuries? Well, I'm not a spine surgeon and I don't operate on the spinal cord. However, sometimes we need to find our answer outside of the spinal cord, and I think it's important to know early when to do so and even late when to do so. Depending on the spinal cord injury, we have to treat these based on the deficits that are present. A lot of times this can be managed with either nerve transfers or muscle transfers. Now, the interesting thing with the spinal cord injuries is oftentimes the muscle will remain viable for longer than it does in the case of peripheral nerve injuries, because there's still some sort of a trophic feedback and signal to the muscles. So let's say a patient has an isolated foot drop from a spinal cord injury. We could still employ the same nerve transfers that we would, distal nerve transfers for the foot, or tendon transfers for the foot. You could take the nerve that would cause the big toe to crunch down, the FHL, and we could transfer that to the muscle to the tibialis anterior. So instead of bending your toe, it's going to raise your ankle. The same thing can be said. We could take the nerve that would cause your foot to scrunch and we can move that to the peroneus brevis to allow you to evert. So that way, instead of needing a foot drop brace, you can actually go ahead and walk on it. Now, it's important to do this before there's atrophy. So while the timelines are not as specific as you would have with, let's say, a nerve laceration or a gunshot, we don't know necessarily how long we have. So in a cut nerve, we say that, in the upper extremity, you have about a year to fix it. In the lower extremity, also a year, but depends where along we are. Within a year, you really do want to address this to have the best possible outcome. The earlier, the better. Given a spinal cord injury, you want to follow it early on with serial nerve conduction studies and EMGs. The second your spine surgeon or your neurosurgeon thinks that it's unlikely to have recovery, you would want to come and speak to a peripheral nerve surgeon and find out what your options are for nerve transfers. And if it's late in the game, then you want to talk to your peripheral nerve surgeon about what kind of tendon transfers might be able to compensate for the missing functions.